technique for ROP. Dr. Parijat, please.
Thank you, Dr. Debender. So, I'll be talking about photoablation for ROP. So first we need to know when to laser, right? So ETROP has given us guidelines which have been around for 2003. It's stood the test of time. We've been doing it for like 20 years now. And by and large, it works very well. Zone 1, stage 1 to 3, zone 2, stage 2 to 3, you treat it with plus and the disease tends to go away. But with the advent of anti-VEGF, a lot of these indications are changing and laser is now losing its charm in some of the zone 1 diseases. Let's see a few situations where laser might not work and you might try some other treatments before you try and laser. So the pupil is not dilating, there's no need to struggle with laser now. You can possibly go in for an injection first. And once you do that, pupils dilate well, and then you can go ahead and do laser if you want to do it, and also have the additional effect of anti-VEGF to work from your side. This is how typically a zone 1 laser would look like, and this has its own limitations like limited visual field, poor macular perfusion, and high risk of myopia. So all this in 2020 might not be a good option with the availability of anti-VEGFs, and in these indications, if you have a case like this, with only this much retina available in ROP, then it's better not to laser these eyes. It's better to inject an anti-VEGF and let the retina grow. And once it grows to a significant size after anti-VEGF injection, then possibly in 6 weeks, 8 weeks, you can go ahead and laser this, or when the recurrence tends to occur. So these are some of the modified indications of where you would like to do anti-VEGF instead of laser. Now, where should you perform the laser procedure? So we perform in the AIIMS and ICU for babies which are inborn, and this is a pediatric high dependency unit which is 6-bedded in ICU at RP center where we perform these procedures. How to laser? It's very important first to take the consent. You have to explain to the parents what's happening to the baby, what's happening to the eyes, the need for follow-up, the need for laser. Will it get control? Will it not get control? All this needs to be very clearly explained to the parents so that they can get the procedure done and continue follow-up as well. The baby needs to be warm, it needs to be dry. You can feed the baby 1 hour before the procedure and dilate half an hour before the procedure and put the drops 2 times with punctal occlusion. Typically we put this eye drop which I'm showing you here, it is made by Rockler Pharmacy. It's also available commercially as well in the name of Tropac P Semi, I think. And so it's basically 2.5% phenylnephrine and tropicamide 0.5%. This is much less than the commercially available full strength which you use in adults. Both eyes are done in one sitting because these babies are often sick, and after one procedure, the baby can get sick and you might not get a chance to do the other eye, which can worsen. So better to do both the procedures in a single sitting. This is just to show you how a procedure is being done. You see, proper precautions have to be taken. Laser goggles have to be worn, and you wear gloves, and the child has to be immobilized. And this is how typically a procedure for laser would be done. So the child is small. You see, even though the feet are moving, still you can continue the procedure. A bigger child, possibly you need to immobilize a little more. Managing pain is very essential when you do these laser procedures because typically we do it under topical anesthesia. The Western world likes to do it under GA, but many of our anesthetists will not take up a 34, 36 child for GA. So this is what we use at our HDU. It's an injection fentanyl, 1 microgram per kilogram bolus followed by 1 microgram per kilogram R infusion. We combine with paracaine topical drops, and you can also give dextrose by mouth and paracetamol post-op. But still this is not enough to treat the pain for laser, and possibly GA is obviously the best if it can be provided. Where should you laser? This is the avascular retina marked by the green arrow. This is where actually you have to laser because that is where the ischemic stimulus is coming from. You don't laser on the ridge because if you laser the ridge, there's a chance you might cause a bleeding there, or it might further incite further traction and proliferation. This is how typically a regressed ROP would look like. You see the laser marks are not as beautiful as Dr. Shashank has shown. So there you like to give one width apart. Here you like to give semi-confluent type of laser because the more ischemic retina you burn off here, the more the disease will come under control. So you give spots. You don't need to give a very beautiful kind of thing because the child is moving constantly. So you give semi-confluent spots, and later they also bloom and trying to merge with each other. But you will see that the plus disease has gone away and the ridge which was there has gone away. So there's no exact number of burns which should be given. The idea is to ablate the peripheral retina. So you can't say 700 spots, 1000 spots. It depends on the person who is actually doing the laser. Scleral indentation is a very important component of ROP laser. You need to stabilize the eye, rotate the eye, and all this is happening because the child is under topical anesthesia. The child is constantly moving the eye, and this is typically what a Shochet depressor looks like. It's got a bulbous end, it's got a tapered tip in one end, and you can use it to indent the peripheral contrast structures. For people who start doing ROP laser, the typical problem with scleral indentation is that we are used to doing, as Dr. Ajay very nicely showed, we are used to doing it, you see the lattice and you laser around it. Here you see the area, you laser around it, but if you see on the right side photo, what I'm trying to show is many times a large strip of area which is marked by the red arrow is left unlasered because you don't see it. You laser behind it, you laser in the indent area, and you don't laser the fold where it is often left behind. So in these areas you indent and then you laser on this slope, and then you will be able to cover this area. Laser in APROP poses a lot of challenges because you don't exactly know where to laser. So this is to show you a fluorescein angiogram. So the newcomer starts to think, the blue line is where, they need to laser, because that is where you can see the blood vessels are there. But actually the red area is where, you need to laser till, because you see these are avascular loops. So if you don't cover the avascular area here, all this disease is not going to go away. So you need to be very careful in treating APROP and beware of the false junction. So just show you a magnified view of the same. You see all these false loops are there. So you don't need to do an angiography to look at this. You can just see it just like this, and you realize that the color anterior to it and the behind it is the same. So this is all avascular retina, and the ridge is much behind. Another important tip when you start doing laser in cases where the pupil doesn't dilate, obviously nowadays you should be trying anti-VEGF first in pupils which don't dilate, but if you want to go ahead and do it with laser, you start to give the spots, and once you give the spots, the pupil will start to dilate. So if you can get in a few spots in a pupil which is small and which fails to diffuse to dilate by the usual methods, once you start the spots, you will actually find that the pupil does start to dilate 4-5 millimeters, and you will be able to complete the procedure, if not the whole periphery, at least the posterior part. Posterior barrage laser also is performed in many of these eyes. A lot of people like to do it in avoidance of not to give anti-VEGF or to prevent surgery in some manner. So we also like to do it in some of these cases where it's progressing and the disease does tend to go away. It basically has to provide anchorage and deals with some of the posterior areas where, and Dr. Shanmugam also showed some of nice photographs about posterior laser. So this is how we also like to do it, and it works very well in many of these cases. Let me show you some things how not to laser. So many of the cases which we get come lasered like this. So you see these kind of lasers are of no use, because unless you take care of the entire ischemic retina, all this ridge and everything is not going to go away. So you need to go ahead and ablate the entire avascular retina if you really want this disease to go away. Doing a half-hearted job and just doing this much doesn't serve any purpose. This photo I like to show often because this is a child of a doctor. He was very concerned my child might go blind due to ROP. The blue line shows actually where the ridge is, and the entire retina otherwise has been lasered. So these kind of things happen. It's not so rare as we would like it and imagine it to be. It happens because people are lasering in tough situations. They try to think this is the nasal retina. The landmarks are not very clear. So you have to be very careful where you go and laser. You have to be very clear. You can see the blood vessels, you can see the ridge, you can see the avascular retina, and only then you go ahead and laser. If you're lasering the posterior retina, it's better to keep on looking at the disc and macula again and again so that you don't inadvertently laser this part. So a lot of challenges are there which newcomers encounter. So I'll just cover a few of them. Many of them, people who start doing the laser, they find that the media is hazy. So once you start doing that, basically the problem might be the cornea is getting dry. So you have to keep the cornea well lubricated. The assistant should keep on putting lubricant drops. Sometimes you press too much. Newcomers like to get to an area where you can't see, and you keep on pressing. So go to an area where it's easier to see. As you keep on indenting, the eye will continue to become soft, and it will become easier to laser that particular part. So don't keep on pressing hard, otherwise the cornea will get edematous. Sometimes the optics are dirty. Someone has touched the lens, or maybe you have touched the lens, and now it's dirty in that part. You clean that. Fogging is a huge problem, especially people who are wearing spectacles, or if you've got you're heating up and you're getting sweaty, it's going to fog. So you have to clear off the fogging, otherwise it's going to happen again and again. Many times people are stuck with poor laser reaction. So you have to focus a sharp point, as previous speakers have very rightly mentioned. You move away, get a sharp point. Many times the cornea is dry, the laser is reflecting in abnormal ways. So you get a sharp focus point, then only the laser will come. Many times you're lasering the posterior retina, maybe the laser power has to be tweaked and increased. In the peripheral retina, a lesser power might work in a better manner. And if you are really trying laser and laser reaction is not coming at all, that means that there's a lot of retinal traction there. So you should try and in another area. If it's coming in another area and it's not coming in this area, maybe it's an area of retinal traction and it will not come here even if you try to increase the power. So that makes you aware of that. Many people complain of neck and back pain, so it's a posture problem. So if you're tall, it's better to raise the table height. If you're short, it's better to sit on a stool and rise. The position is very important. Youngsters I see now like to do it in the sitting position, and obviously going to here for the long haul, then you have to do yoga. You have to strengthen your neck muscles. You cannot keep on doing this for 20 years and you think you're going to just do like it was the first day. If you continue to get sweaty and tired, then you have to have temperature control in that area. somehow, pediatricians like to fry us up when we try to do laser. So you can, if you're going to do this for 2 hours, you can't do constantly, sweating and in an abnormal, just I'll take 1 minute more. So you can't keep on doing it in a sweaty manner. You can't have a radiant warmer working on your head when you're doing the procedure. Obviously the nursery, they keep the temperature a little higher, but it doesn't mean that they have to put heaters all around you and fry you up. Wear light clothing, keep hydrated. And this is the last slide. Laser takes forever. Many newcomers who start, they just continue to do it and it doesn't end, I've been lasering for 3 hours, the procedure doesn't seem to finish. So the pediatrician also gets, bugged, this guy can't laser, send me someone else to laser this child. So obviously laser training is very essential. You train in adults first and learn the procedure. Media haze I already covered, has to be fixed. And there's a need for speed, the child is moving. You're indenting, the child is moving. There's no need for beautification here. You want to do anyway semi-confluent spots. And if you keep on doing like, at 300 milliseconds or 400 milliseconds, before the next spot comes, the eye is already moved. So you have to do it faster. The interpulse duration has to go down, otherwise you can't finish it. And in zone 1 small pupils, obviously you can think of doing anti-VEGF first, rather than, struggling with laser and, trying to get only 100 spots in 1 hour. Try anti-VEGF first, it might be a better indication in zone 1. And if the child is totally uncooperative, maybe you have to fix the pain issues in an ICU. If the child is constantly wriggling with pain, he will not let you do the procedure. And maybe the child is too big for this and you might need GA, which might be a better option in this case than doing under topical anesthesia. So thank you so much.